You're listening to Streetside, a Street Medicine Institute podcast.
Hello and welcome to Streetside and our third segment on interventions in New York City for street medicine. Today we have our co-host Poyani Bavishi interviewing Dr. Aaron Fox. Dr. Fox is the director of the Bronx Transitions Clinic, which provides medical home to persons with chronic health conditions who are recently released from incarceration. His expertise is in opioid use disorder and the related problems of HIV, incarceration, and chronic pain. Welcome, Poyani and Dr. Fox.
Welcome, Dr. Fox, to Streetside. Thank you so much for being here today.
Yeah, thanks for the opportunity.
So before we get started, we'd love for you to just say a little bit about yourself, what you do, and how you got into the work that you're involved with.
Okay, sure. So I'm Aaron Fox. I'm a professor of medicine at Albert Einstein College of Medicine in the Bronx, and I'm a primary care doctor and addiction medicine physician. I run a small clinic called the Bronx Transitions Clinic for people who are coming home from jail or prison, but I'm mostly a researcher. I do research on opioid use disorder, and then the overlapping problems of HIV, chronic pain, the criminal legal system.
Great. And just for our audience, would love to understand what drew you to the intersection that you work at, and if that was something you originally saw yourself doing or how you found your path there.
I wanted to be a doctor for a long time, and I grew up in the 90s. I think the major problem back then was HIV. And when I was starting college in 1996, it was right when protease inhibitors came out. So there was finally the highly effective medications for HIV. So I really pictured that I was going to be a primary care doctor for people with HIV. And that was kind of my dream job. And I think during college, I was involved with activism and housing activism. And I remember right before I started medical school, it was the summer of 2000, and I went to a protest at the Republican National Convention. At that time, it was in Philadelphia. We were staying in this abandoned area, the Kensington area of Philadelphia, and we were learning about housing and all the issues in Philadelphia that had led to, the concentrated area of poverty and substandard housing in that area. And then went to the protests, and there was a lot of enthusiasm about the activist spirit. And then I ended up going to medical school, and the first month of medical school was histology. We were in the lab looking at microscopes, and I was like, is this really what I'm getting myself into here? But I think, I ended up choosing to go to Einstein because of the history of social medicine at Montefiore and Einstein. And it's really the way that I envisioned my career, to learn about social medicine and to bring that activist spirit to medicine. And I think at Einstein ended up meeting a lot of faculty members who were involved with the community. And in particular, one of my mentors, Shanazo Cunningham, was doing outreach to single room occupancy hotels, which were emergency housing for people with HIV at that time in New York City. And being exposed to that type of outreach, where we were working with harm reduction agencies, and the staff at the harm reduction agency would really engage with the participants who were living in the single room occupancy hotels. And then I was a medical student, and the residents and the faculty would see people and see if they wanted medical care, HIV care, if they wanted an appointment to come see them at clinic. And that type of partnership, the collaborative team-based care, was very appealing to me. The outreach aspect of it, getting out of the clinic and seeing what people's lives were like, was really appealing to me. And I remember one of the first times I went on outreach with the team, the medical students were doing flu shots. I was supposed to give a flu shot to one of the participants. And again, this is outreach with the harm reduction agency to people who use drugs, people who inject drugs, and doing the syringe exchange in the hotels. And I have very shaky hands. So I had a flu shot, and I was getting ready to give the participant the first injection in their arm. And they grabbed the syringe from my hand and gave it to themselves. And they're like, yeah, I think I can do that myself. And for me, it was, a lesson in humility, that people know a lot about their health and their wellness and can take care of a lot of things for themselves. So I think that type of outreach has really informed most of my career. Again, coming back to the team-based care, trying to get out of the clinic, meeting people where they are.
I love that story. And I think that example of humility is one that always comes up in these outreach type settings, especially. There's so many ways our patients show us that they really know themselves. Sometimes not as graphic or explicit, but nonetheless, they're great stories that we get to be a part of. And I'm curious about, it sounds like you had a lot of like housing justice as part of your journey and outreach for people in the single occupancy rooms. How did you find your way to working with people that were transitioning out of carceral settings?
Well, so for the transitions clinic, I was at the beginning of my career, I was more of a clinician educator, working with the primary care social internal medicine program at Montefiore. And all of the residents do social medicine projects. So the transitions clinic actually stemmed out of a social medicine project that several of the residents had worked on. And one of them, Ross McDonald, ended up being the medical director at Rikers Island, the New York City jail system, for a long time. But when he was a resident with us and some of the other co-residents of his, they started the clinic and wanted to work with community organizations. So we first did outreach to the Transitions Clinic Network and Shira Shavit to learn about the Transitions Clinic model. And I can come back to that in a little bit and describe what that actually means. But Shira came and gave grand rounds to our department. We learned about this Transitions Clinic model. We started doing the transitions clinic at the beginning. A few of the faculty members and myself, we would volunteer on Saturday afternoons to see patients at the community health center where the primary care and social medicine residents already had their continuity clinic. But it was the partnership with the Osborne Association at that time, who provide reentry services for people coming home from jail and prison. They helped us identify a community health worker, someone with lived experience of incarceration and training in health systems navigation and patient education, and working with the community health worker who would build a relationship with the patients, vouch for the clinic, and then make the referral and accompany them to the community health center. We started running the transitions clinic, and after the residents finished up and graduated, I ended up continuing as the faculty member. And we've been doing it for about 15 years now. It's really incorporated into the training program and an opportunity for the residents to learn about care for people with experience of incarceration, and also learn about working directly with a community health worker.
And it's incredible. I think we're catching up to the idea of having people with lived experience be the center of the initiatives that we use to involve our community members more, but it sounds like this was part of the transitions clinic at its core. And so, yeah, I would love for you to describe to our listeners who aren't as familiar what the transitions clinic is and the model of care that it uses.
Yeah, I mean, that's really the core of the transition clinic model, working with a community health worker who's very well trained in the health needs of formerly incarcerated individuals. So the Transitions Clinic network is national. I believe there's more than 40 sites around the country now. There are usually primary care sites, a patient-centered medical home where people can get primary care, HIV care, treatment for substance use disorder. We do some mental health care and referrals for higher level psychiatric care. Some of the other clinics in the network have a lot more robust services like food pantry and clothes for people if they're going for interviews. But it's the partnership between the clinician who's trained in the needs of formerly incarcerated individuals and the community health worker working together to deliver the care. And some of the sites also have a little more medical legal advocacy that they can do. But I think it's really having a site that's welcoming to people who are coming home for jail or prison, where they can identify this as going to be the source of care. And early on, when we had more valuations of several of the transitions clinic network sites, those studies showed that the model could prevent people from going to the emergency department unnecessarily and could save money for the healthcare system. And certainly we believe that we can deliver really high quality patient-centered care with making sure to prioritize people's dignity and wellness.
And I think that focus of dignity and wellness and of honoring people's experiences is so central to what you do. I'm curious about hearing your story from being a resident all the way until now. Do you remember what it was like when you kind of first went to the clinic and experienced it, and what might have been surprising to you then when you were first exposed to the transitions clinic?
Yeah, I mean, I think there was a few things that were surprising. For one, I was surprised that the HIV care that people were getting in the New York State prisons was actually pretty good. That people would come home on modern medications and would report back that they would see the specialist, and the specialist also treated them well. So I think, and I learned afterwards that in New York State there was monitoring of HIV care within the Department of Corrections. So that external monitoring is one of the necessary components to make sure that there's a high quality of care. So that was, I was pleasantly surprised by that. And then something else that I probably shouldn't have been surprised about, but so many people coming home with multiple mental health diagnoses that weren't really clear, that would have diagnosis of bipolar disorder and schizophrenia and schizoaffective disorder and psychosis, NOS, or not otherwise specified. And you're just thinking to yourself, like, what's going on here? And of course, it's incredibly challenging for someone to get an accurate diagnosis in the carceral system. Part that I should have known better, just so surprising how little access to care people had before incarceration. People who were struggling with mental health problems their entire life, but never saw a doctor or a clinician for their mental health before they were incarcerated. And that was really the first time that they were receiving care.
Absolutely. And we had talked a lot about carceral settings being a large place where healthcare, mental health care is provided. But this period of transition out of these carceral settings is one that is less talked about. And so I'm curious about what challenges you see patients come in with specifically during this transition time. Like, what is challenging from a healthcare aspect, as well as kind of adjusting back into the setting from which they came or which they're going?
Yeah, I mean, that's a good question, because there's the structural issues, and then there's also the individual level issues with the adjustment. But especially as a opioid researcher, that first 2 weeks when people come home from jail or prison, they're at very, very high risk for mortality. And that's both from drug overdose, but also very high elevated levels of mortality from other causes like cardiovascular disease, suicide, homicide. So really there was this classic study, which probably 20 years ago, from the Washington State prison system, where Ingrid Binswanger was reporting on mortality after release from prison. And in that first 2 weeks after release, mortalities increased by more than 12 times in comparison to the general population. And if you just look at drug overdose deaths, it was 129 times greater than the general population. So that first 2 weeks is really so critical. And mind you, this is 20 years ago. This is before fentanyl. So I haven't seen something more recent, but I've certainly had patients who have come home, weren't taking medications for opioid use disorder, didn't want to start, and we did see them right away, didn't want to start buprenorphine, and then ended up overdosing, just because people tolerance goes down if they're not using as frequently when they're in prison. And if they use the same amount of opioids, or in, the modern era with fentanyl being in opioid supplies and being so much more potent than what people may have been used to 20 years ago before they went into prison. It's just such a risky period. Prisons are doing a little bit better in New York State now because of recent legislation. All the jails and prisons need to offer medications for addiction treatment, and people are coming, if they need methadone or buprenorphine, they can actually access it in prison and jail, and they're coming home with medications for opioid use disorder. So that's gotten better over the years. Issues with health insurance, people's health insurance gets either terminated or suspended when they're in prison. Medicaid won't pay for medical care in carceral facilities. So some states totally terminate Medicaid. New York suspends it. So probably when we started, it was much more difficult. People would come home with a suspended Medicaid. We could see them at a community health center, at a federally qualified health center. But if they needed other aspects of their care, it was harder for them to get. That's also gotten a little bit better in New York, with people having their health insurance, the applications filed before they come home, and their insurance being activated before they see us at Transitions Clinic. So those are two structural issues. But I think, individually, I think what I've seen over the years is that people are excited to be home. People are grateful to be home. I've had this experience of people being very optimistic, but then if they're living in the shelter system or they're doubled up with family and can't contribute to the rent and it's hard for them to find a job because of the record, that they feel like a burden to their family, and there's a level of frustration that builds up. We keep telling ourselves as a society that we believe in second chances and we're a compassionate society, but then people don't really have a second chance, and there is the perpetual punishment of having a record. So I think that level of frustration ends up being really challenging for people. I also think that's where the community health worker is important, and being able to link people up with a community health worker who has contacts in the community and can help people identify sources of support, a broader network of people with similar experiences, that can be helpful for people.
Yeah, and the idea of expectation not matching the reality when you come out, I imagine must be devastating in some situations, especially if you left behind a specific type of community that might not be there when you come back. And I'm curious about, in this time of transition, when you're talking about the challenges that you just mentioned, do you feel like those are common reasons that patients might not come back to the transition clinic, or is that something that you see because of this community health worker or because of the unique approaches that your team takes? Do you feel like that has been helping retain some of the patients during that transition time?
Yeah, I mean, I think we have the selection bias of the people who come to the clinic already are usually connected with a community organization. And we work with the Osborne Association, the Fortune Society. So, they're the people who are engaging in the helping services. Osborne and Fortune are great. They have a lot of services for people and can help them with job readiness and housing placement and care coordination or case management. So accessing their benefits, they can do a lot of that for people. So I think that does help people stay engaged in care. But there's a lot of people that we just never even see. I think it's doing biomedical research. We study the people who agree to enroll in the studies. And I know with a lot of the folks who are working in street medicine, you all do the work doing outreach to find the other people who are more excluded from the system. And, I think with my research, we've tried to do more outreach and also identify the people that we're missing. But in transitions clinic, I think we do a pretty good job of engaging people in care. A good number of people do drop out. I think, some ways they get a job, things are more stable, that the clinic just isn't convenient for them to come back to. So they find a doctor that's a little more convenient for them. But then also some people who the mental health challenges or substance use disorders really get in the way of engaging with primary care, and when we don't see them.
Yeah, and I'm curious about the aspect of building trust in this particular setting. In street medicine, something we talk a lot about is we have the advantage of meeting people where they are physically at, and at times that can help with that feeling of having some comfort and some feeling of autonomy and control over the situation to the extent that a patient might be able to have in that setting. But I'm curious about, in the transitions clinic, how you build trust in that setting, if that looks different than how you might in other healthcare settings.
Well, I think the advantage, again, working with the community health worker is the community health worker is good at building trust, and that gets transmitted to us as the clinicians. And I've been working with Richard Medina, who's a community health worker with us for a very long time. People really love and respect Rich. So I think, if Richard says, oh, Dr. Fox is going to treat you okay, then it really helps us in that trust building aspect. Our clinic is embedded within a community health center. It's not an independent clinic. I don't even know if some of the patients really know that it's a specialized program for the reentry period. And I think most people probably don't want to be treated any differently. They just want to come to see the doctor, and it would be weird for us to ask too many questions about what it was like to come home from a jail or prison, the first time that we saw them. So, I mean, I think one of the things that I'll do, especially since we get a lot of referrals from Osborne and Fortune, I'll say, oh, were you referred from one of these programs? And really try to indicate to them that I know what they're going through. And they'll say, yeah, I just was referred, or, I was referred from Rikers, or I was, referred. Then I'll just welcome them and say, well, welcome home. I'm glad that you're here. We're going to take good care of you. Just get that out of the way. So it's not a surprise if something comes out that they were, just in prison for 20 years and coming home, and want to make it comfortable for them to bring that up if they choose to talk about it more. But I also think, again, the aspect of humility, it takes time to build trust with people. And specifically, I think in that reentry period, the stakes are so high for people. And especially since we do a fair amount of buprenorphine treatment for opioid use disorder. And if people are on parole and they have a parole officer who's checking urine drug tests, and then at the clinic, the norm is to check urine drug tests. And, you can tell them over and over and over, this is confidential, this isn't going to go to your parole officer. But the stakes are so high, sometimes people understandably just don't believe you from the beginning and are a little bit more guarded. So usually when I'm working with the residents, and I'll just tell them that the trust takes time. Things might come out that people are telling you one thing, and then it turns out that it's different. Sometimes people will tell me, especially when we're talking about opioid use disorder, I'll bring up, oh, well, if you want to start on buprenorphine, I can write you a prescription today. We have a lot of experience prescribing. We aren't going to give you a hard time about it. And people say, oh, no, don't need it. Haven't touched any opioids. And then a couple of weeks later, they can come back and say, oh, well, actually, something did happen. I need it. That's okay. I think it does take time to build trust.
Yeah, absolutely. I think you touched on something that I don't know that we always think about, which is, the similarities between the systems that we work in terms of the medical system and carceral settings. You talk about urine drug screens, which are confidential, but are obviously something that could be similar between the environments. I think about time that I've spent working on the inpatient psych unit and having that medication window, which people walk up to. And it's hard when you have different, especially the psych unit, of course, the rooms are cleared out. They're quite similar to some of the settings that people have come from. And so it's very hard to overcome these environmental factors that are involved and still communicate that your purpose is entirely different than the one in which they have seen a lot of these similarities in the past. So that definitely resonates. When you're talking about your work in the public discourse, I know you do a lot of advocacy work, and I'm curious about what a common misconception you think that either other clinicians or policymakers have about treating either opioid use in this population or healthcare needs in these populations. Just any observations you might have from your time doing advocacy work.
Well, I think the biggest misconception, especially around this issue of opioid use disorder and substance use disorder, is that, the best way to get people help is to lock them up. And, if people get clean when they're incarcerated, then that's the way for people to turn their life around. I think that's a huge misconception, because most carceral facilities don't really have high quality substance use disorder treatment to begin with. More recently, there's been better access to methadone and buprenorphine in jails and prisons. But there was just a recent study a few years ago where I think it was 2022, where they were looking at a random sample of jails, and only about 13% of the jails reported that they would offer medications for opioid use disorders to all people who needed it. More jails and prisons will have medication treatment available for some people, for like pregnant people if they need it, or if people were already taking methadone in the community, then they can continue it. But newly starting medication is very rare. So those services just aren't available to people. And I think a lot of times in the discourse about jail being a good place to treat people, or jail being a way for people to turn their lives around, I think the discussion doesn't really include the amount of trauma that people go through in that process of incarceration, especially if people are put in solitary confinement, because using substances in carceral facilities is contraband and can lead to punitive measures and solitary confinement. So here, someone doesn't have access to the first line treatments for their substance use disorder. They continue to use, then they're put into solitary confinement. And all of that builds up. The question was about misconception. And in the New York Times, Nicholas Kristof wrote an article a few months ago telling the story about one of his childhood acquaintances who was able to seek medical treatment in prison and was able to get off the streets, and proposing that, well, maybe progressives should be more open-minded about jails and prisons. And I definitely think there are people who've been able to get care in those settings, people who've been able to turn their lives around, people who feel very strongly, who engaged in 12-step programs in a recovery community. And that was the first time that they needed the external pressure to push them towards that. And that, there was negative contingencies of going to jail, and fear of being locked up again was very important for them to stick with their recovery goals. The thing that concerns me is that those people tend to be the people who have the microphone telling their story, and it's an inspiring story, but it's an anecdote. And the people who come home from jail or prison and overdose and die aren't telling their story. So I definitely don't think it's the best place to treat substance use disorders. Like we talked about, I think the jail in and of itself can be a toxic exposure for people. And also just, simply speaking, if jail worked really well, we wouldn't have such high recidivism rates. If people went to jail and then their addiction was cured, then they wouldn't go back. And, more than half of people who are incarcerated with, sometimes people will talk about a substance related scenario, meaning that they either themselves have a substance use disorder or had a drug related offense. More than half of them, it's not their first time being incarcerated, that they had been incarcerated more than once, and typically 3 or more times. So the idea that's an easy fix for people and something that we should be expanding, I really think is a mistake.
Absolutely. And I'm curious if over your time doing this work, if you feel like perspectives around this have changed notably, or if there are some parts that are changing about how people are approaching this work and others that you're finding more difficult to change.
I do think attitudes are changing, and especially here in New York State, there's been more attention on integrating treatment for opioid use disorder into the carceral system, even before the law changed requiring it in all jails and prisons. For example, in the Albany County Jail, they developed an MOUD program years ago. And I remember the sheriff himself was a very strong proponent of it, and really having that buy-in from leadership is really important. And I remember hearing the staff talk about it at a meeting, and one of the program directors was talking about how the correctional officers went from a point where they were feeling very skeptical. Buprenorphine or Suboxone can come in a film form, and for a long time it's been smuggled into jails and prisons, and people sell it. It has a high value. I would argue if you're not treating someone's addiction and then they buy what they need, that it's understandable. But the correctional officers are thinking about this as contraband. Why are we giving people buprenorphine or Suboxone when for so many years we were trying to keep it out of the facility? But you go from a point where people are coming into the jail in very severe withdrawal, vomiting, diarrhea, irritable, getting in arguments, to a point where they receive the medication. It treats their withdrawal. They're grateful that they have access to treatment and can start on a medication that can be life-changing for them. And the correctional officers are recognizing, oh, wait, this creates a more orderly jail. I actually want to work in the unit where we're doing medication for opioid use disorder because people are stable. And that's a more positive environment to be in. So I do think, that positive reinforcement that you start this program, it's working well, people learn from it. And then, the sheriff talks about the program to other sheriffs. And it's not, me as the nerdy doctor saying, you should do this, but instead, their colleagues telling them, no, actually, this is working well. This is making things better for both the people in jail and the staff members.
It sounds like you reached the right people that you needed to make the change. Yeah, because we often keep our successes kind of within our own communities, right? And we tell other doctors about how well this is working. And we do need buy-in from within our community, of course. But importantly, we also need the facilities that we're working with and also the communities that people are returning back to understand the benefits of substance use treatment and what we're doing here. I just want to shift gears slightly because I know you have a lot of great experience in terms of research that we haven't touched on really. And your research has included a lot of innovative approaches, specifically when we're talking about expanding services and thinking about service delivery. And I would love to hear a little bit about some of the innovation that your team has come up with and is researching now?
Yeah, I mean, I think especially for, street medicine practitioners and students who are interested in street medicine, that idea of outreach and meeting people where they are, it's also infused my career and has really inspired a lot of the research and work. So we have a national study right now where we're examining implementation of buprenorphine treatment on site at syringe service programs. And what that means is already about 20% of harm reduction agencies or syringe service programs around the country already have a way to link people to medications for opioid use disorder. But what we've done is we've identified 8 different syringe service programs from around the country that don't already have an MOUD program, because there's clients of the syringe service program who have opioid use disorder, who are using the syringes, using other services at the sites, and maybe had bad experiences going to see the doctor. Levels of stigma and discrimination in medical settings for people who use drugs are quite high. So if people are reluctant to even go to a community health center or a drug treatment program to see the doctor to get a prescription for buprenorphine, or to go to the opioid treatment program, the methadone clinic, to start methadone treatment, what we're looking at is, well, if we have either through telehealth or an on-site prescriber the opportunity for them to start treatment on demand. So somebody's picking up syringes, they have a good relationship with the staff, they're talking to the staff about, I think I want to give Suboxone a shot, or I want to get a shot of Brixadi, then we can write the prescriptions right there. So the study will look, the sites that we're working with are going to do a period where they're following their usual practices, where they're referring people who are interested in MOUD out to community programs. Then we're going to implement the buprenorphine treatment program on site, train a provider in what we call low threshold buprenorphine treatment. And the principles are informed by harm reduction and flexibility and openness, having a welcoming attitude. And it's also a randomized study that the sites are going to implement the program at a different time. So we'll be able to compare before, when the sites were using usual practices, to after, when the sites have implemented the buprenorphine program. And then we'll also be able to compare between sites because of the randomization of the timing. So this, for me, I mean, it's not all my work. I think my mentor, Chinazo Cunningham, started this work 15 years ago. And then a lot of my colleagues at Montefiore Einstein have been doing it for a long time. My colleagues work with On Point NYC, which is a harm reduction agency in New York City. It's the first formally recognized overdose prevention center in the United States. And both of those, they have 2 offices, one in Washington Heights, one in Harlem. And both those offices have a low threshold buprenorphine treatment clinic. So we've been doing it already in New York City, learned a lot about what patients are looking for. And for the implementation study, we have a site in South Carolina, a site in Louisiana, a site in Milwaukee, Wisconsin, and Duluth, Minnesota, and Los Angeles, and Washington, D.C., Grants Pass, Oregon, and in Roswell, New Mexico. So these are really, we have geographic variability of rural sites, we have urban sites, and we're going to be able to bring the treatment to those sites. But also we're hoping that the sites can build capacity to do higher levels of medical care. So if you have this relationship with a buprenorphine prescriber, after the study's over, can they also do wound care? Can they do HIV care? Can they do hepatitis C treatment? So we're hoping that we'll be able to build capacity for the sites.
Such important work. And it sounds like you're always pushing the envelope to see what the next step can be too. How incredible that all these different locations will be delivering this. And also, I'm interested to see what types of barriers there are to implementation in these different places and how these locations overcome those challenges. I think it'll be some really helpful information for us moving forward.
I mean, already meeting the sites have been amazing, because the folks doing harm reduction work out in the community in some of the areas like Baton Rouge, Louisiana, and Greenville, South Carolina, that are very different than New York City. And in Grants Pass, Oregon, the folks who are doing that work in communities that are more conservative than New York City and where there's fewer resources, they're just really amazing people doing amazing work.
Speaking of amazing people doing amazing work, you have such rich experience in this field, and I'm curious for our earlier career investigators or trainees what lessons you would want to impart regarding health equity or community-centered research that you hope that the people that you mentor carry forward in their work.
Well, I said I went to Einstein. I've been at Einstein for 26 years now. In my fourth year of medical school, I did an elective called research-based health activism. And it was this idea that you want to design objective research, ask a meaningful research question that is going to make real world change in the community and use rigorous research methods to evaluate that question. You can't come into the work knowing the answer because that's not how research works. But the research can't end with a publication, that the next step has to be advocacy to actually make the change if you've demonstrated that the project that you're working on or the question that you're answering, if it worked. So that advocacy point, what we learned, this is more than 20 years ago, in pairing the research protocol with an advocacy plan was to identify, when you do have findings, who are the people in the community who can make change, and how do you build the type of power in the community and the type of coalition to enact that change. So I guess that's my message to my mentees and early career investigators. Right now there's more skepticism about research, and I think that terminology about research-based activism will rub some people in my field the wrong way, that no, we're supposed to stay out of the fray. We're supposed to be objective. Right now, look at, all you activist doctors have created second guessing about the science. I still would push back that I think we can use objective, rigorous methods. In the trial that I was talking about before, the Clinical Trials Network is sponsoring it, and we have very, very rigorous methods. I don't know if it's going to work, but I can tell you if it does work, that I'm going to do everything that I can to not just publish a paper, but also work with those communities to make sure that that the programs are disseminated, but also at a structural level. Senator Maria Cantwell from Washington State proposed legislation that would create health engagement hubs, which are basically like low threshold buprenorphine treatment programs at syringe service programs. So like integrated medical care and harm reduction. And I think it's a great idea. And if we can provide evidence for that model that it works, and that's one of the things that helps support that legislation, that's to me a win-win. That's not somehow antithetical to science.
That's such an important point, especially in the way that we're sharing information in this day and age. And I do feel like more people are asking for numbers and data behind kind of anything that you want to bring to fruition in the healthcare setting. And so, yes, doing the work and collecting the data is such an important part of it. But without the dissemination piece and the action piece of it, it's really hard to make this work known in a way that's meaningful. I really appreciate that message.
Can I give one other quick piece of advice? I feel obligated to say this because my mentor said it to me for a decade and I didn't listen, but focusing. I think early in your career, there's so many interesting projects that you want to work on. And I really got to the point where I was spread too thin, where it wasn't just about being tired or burnt out. It was just that the quality of the work suffers because your attention is also spread too thin. So I would say focus, pick something, like maybe one or two things that you really feel passionate about, and do it well.
That's certainly a really important message, I think, for listeners, many of which are in training right now. So, and in terms of if someone listening wants to actually help improve care for people living with HIV or substance use disorders beyond donating, what should they do?
Yeah, I would say identify your local harm reduction agency or syringe service program. There's opportunities to volunteer. I think if you're a practitioner, learning from the harm reduction staff and the peer outreach workers about their approach to engagement, I'm sure will deepen your practices. And, I learned so much from my colleagues doing harm reduction work. I think in this, especially in this political environment right now, for the folks doing street medicine and who are concerned about homelessness. I mean, that executive order from last summer about crime and disorder on American streets that really calls out harm reduction is a warning. And I think for those of us who are in more stable situations. So if I'm working with a harm reduction agency, but I'm a professor with tenure, maybe some of the things that I can say publicly can take on a few more risks in speaking out in support of harm reduction, in support of our patients, not playing it safe. all the time. And I do think, again, New York Times, Nicholas Kristof talking about jail as the solution to addiction, and Ezra Klein in the New York Times on his podcast talking about disorder in the streets and talking about harm reduction in negative ways. I think there's another side of the story that doesn't get as much attention, that's not being told. So being exposed to harm reduction, seeing the amazing work that people are doing, how compassionate the staff are, the high level of needs that their clients have, and how they are effective in meeting those needs. I think that's really important.
Absolutely. And I think on the other end, also a good reminder for providers or people working in these settings to get their stories out there and to add, their dimension and what they've seen to the public discourse as well. Because I do agree that those stories are not being told, and we have people with such valuable experience bearing witness to what's happening. And I think people can sometimes feel like they don't have all the knowledge that they need to comment on a subject, especially something I notice with trainees. And I think it's important to remember that you have the experience and that you are kind of bearing witness every day, even if you don't necessarily register the gravity or severity of what you're witnessing. It might seem mundane to you, but for others, it's really important to hear.
Well, I think from one of our studies, I remember a participant of the study who was using a syringe service program was talking about the staff member and the role that the staff members play in their lives. And we were in a focus group, and people were just talking about the fact that they might go through an entire day and nobody says anything positive to them. Nobody touches them in a supportive way. And the only person who seems to care is the staff at the syringe service program. And, bearing witness to that and being able to, talk about those relationships, that doesn't take expertise. You don't have to be an expert on harm reduction. You don't have to, talk about the randomized control trials of syringe services for HIV prevention, but just being able to convey that really important role that the staff can play in people's lives, things like that can be really touching.
Absolutely. Related to what you were saying earlier about research being a bit more tenuous in terms of funding, what keeps you going? What keeps you inspired to keep working, especially amongst the ever-evolving landscape in which you're working in?
My colleagues. I mean, I've just really always been privileged to work with amazing people, and I've always felt like this wasn't going to be easy work. It's going to be challenging. And working in a team where we're all fighting the good fight, that you're not on your own, that you're not the only one trying to push back against the corporatization of medicine or push back against the attacks on harm reduction. That has made it a really inspiring and sustainable career. And I also think colleagues in my division, my mentors, my mentees, but also, again, working with a community health worker who brings such amazing skills and a different viewpoint to the work, working with the peer outreach workers and the folks in harm reduction. The research coordinators that I work with have a different perspective, and project directors. And, some of the projects that I'm involved, there's one project specifically with the Fortune Society. We're working on a HIV post-incarceration project. And it's really the perfect example of community engaged research where Fortune has their research team, Einstein has their research team, people work together to their strengths, bringing a different viewpoint. And it's really collaborative work. So, all of that is incredibly rewarding.
It sounds like you've built and been surrounded by a really meaningful community of people with a lot of varying strengths. It's a good reminder for us all to branch out of our communities to work together. And question that we ask everyone is, if you could suggest one thing to make the world a better place, what would it be?
Put down your phone. Can I get a crotchety old man for a little bit? I was just on the addiction consult service working in the hospital and doing rounds. And, we have a pretty big team with medical students and residents and fellows. I don't want to call out anybody individually, but I know that people use their phones to look at the electronic health record, but you can also tell that people are distracted as they're on rounds and seeing patients. And for the clinicians, I think it's so easy to lose the trust of your patient. And if they think that you're not listening to them or you're not fully engaged, you may not get a second chance to build up trust again. So I would say put down your phone. But something else that I've been thinking about recently, especially since I was on the addiction consult surface recently, is really how each of us can hold ourselves accountable to making the extra effort, going the extra mile. Because I think a lot of times when we've built up this vocabulary about social determinants of health and structural forms of oppression, and I certainly believe in advocacy, and outside of the clinic, we need to address those systems of oppression. And even within the clinic, we need to understand and contextualize how those structures end up impacting what we're seeing and how we care for patients. But then at the same time, it can't just be about the structures. That there's so many opportunities as an individual to do more for our patients when they need it. And I see it from the fellows. Our addiction medicine fellows are so committed to the work. And whether it's somebody needs an injection of long-acting injectable buprenorphine and they bend over backwards and go back and forth between the clinic and the hospital and get all of the prior approvals to make sure that they get that medication, or something simple like bringing a patient candy and a coloring book and making sure that at a time when they really feel terrible, that somebody's showing them some love. Those things matter so much. And it's really, again, inspiring to me to see that from the fellows. And I'm so amazed that they're so consistently committed to making that extra effort.
It's incredibly beautiful to hear about. And I think the power of presence is something that we don't think about that much in medicine, but I feel like we've all had the experience of a provider typing away while you're talking. And even that can be really distracting. And sometimes I find just like sitting in front of someone, like a paper and pen, just brings down some guards and makes people feel like, wow, this person's really just committed to listening to me. And we forget that that can be therapeutic and healing in itself. So absolutely love that message. Dr. Fox, you've shared so much wisdom with us. Thank you so much for joining us here today and for all the work that you do and for continuing to inspire us every day.
The Street Medicine Institute is a secular, nonpartisan organization. Any spiritual or political views shared by guests on Streetside are their own. They're offered in the spirit of conversation and should not be taken as reflecting the views or positions of the Street Medicine Institute. This podcast should not be used for personal medical guidance. Please consult your healthcare provider.